Good afternoon, everybody. Welcome back. I'm so happy to meet you again in this very important project, really. It is the best treatment of shock by advanced critical care ultrasound. This is what I believe should be the best management of shock by advanced critical care ultrasound. I will give you a very amazing case study recently I saw in ICU. And I will give you a lot of links to help you for the best management of shock. Okay, let us see this amazing shocked patient. A 73 years old male patient, known case of diabetes mellitus, hypertension, ischemic heart disease, bedridden after RTA and bad fracture right femur. He was admitted in the surgical ward 2 weeks ago because of very bad bed sores, which needed extensive debridement and colostomy for diversion of the stool. For the clearance of these bed sores, they needed to do diversion of the stool by colostomy to help clear the very bad bed sores. He was charged 1 week ago on antibiotic. He was presented to our emergency department because of shock. Blood pressure was 50/30 after 1 liter of normal saline and noradrenaline 15 mic per minute. Medical team, surgical team, and the emergency department team decided to stop IV fluids because the patient is known case of ischemic heart disease and he was anuric since admission in ER about 8 hours with rising serum creatinine 2.8 milligram per deciliter. The baseline creatinine was normal and rise to 2.6 milligram per deciliter. They called ICU because shocked patient, known cardiac disease, known ischemic heart disease, and the patient already anuric since admission with rising creatinine. They give 1 liter of IV fluids, start the levofed in rising way, and the blood pressure is not responding. They call ICU. Fair. I saw the patient in ER. He was drowsy, hemodynamic and unstable, blood pressure 60/40, not respiratory distress, with O2 saturation 98% on 2 liters, nasal cannula, anuric with mildly swollen right lower limb compared to the left side. His wife gave a history of severe pain of the left side, of the anterior part of the left side over the previous couple of days, and fever spikes. Lactate came 3.5 pancytopenia, يعني white cell count decrease 3,000, البليتلت 100,000, الhemoglobin 7. So this patient now is shocked. He received 1 liter fluids and levofed 15 mic. Differential diagnosis. It could be septic. Patient is diabetic patient with recent hospital discharge after very bad bed sores with extensive debridement. It could be an element of obstructive shock due to DVT pulmonary embolism, elderly, diabetic, hypertensive, cardiac, and bedridden due to bad femur fracture. He has swollen right side. It could be pulmonary embolism. It could be cardiac. He is known case of ischemic heart disease. It could be hypovolemic. He is cachectic with repeated infection, antibiotic courses, surgical interference, and you couldn't guarantee proper oral intake. Everything could happen in this patient, could be mixed shock, several factors, but you cannot neglect any one of these. Maybe there is main factor causing the shock, but there is other factor can cause this hypotension in this patient. You cannot neglect and you cannot exclude completely. Okay, let us see. Let us start advanced critical care ultrasound. This usual patient in ER with multi problems, trauma, cardiac, infection, a lot of things. You need to clarify the thing. What is the best management of this patient? Let us see. Let us start advanced critical care ultrasound. First, inferior vena cava. It was a horrible subcostal window, so I rely on the lateral view of the inferior vena cava through the liver. As you see here, it was collapsing at the narrow. This patient with known cardiac disease, can give you a clue about the patient is hypovolemic. Second, we'll go to the heart to see what's going on. This is a 4 chamber view. Left atrium, right atrium, interatrial septum, left ventricle, right ventricle. As you see here, from the shock point of view, you see this left atrial septum, it's moving right and left, moving right and left. This movement of the interatrial septum per se give you a clue about hypovolemia of this patient, because the pressure in the atria is not too much, because if this pressure in the left atrium is high, it will not allow the septum to flutter right and left. It will go to the right sides, okay? But this per se give you a clue about hypovolemia of the patient. The ejection fraction, you are talking about 40-45%. You see here, inferior septum is not moving at all. Apex is akinetic. Hypokinesia of the septum here, the inferior septum here, basal part. And the lateral walls, okay. Right side is not dilated. You can exclude the pulmonary embolism in patient to not in respiratory distress with only 2-liter nasal cannula at the oxygen saturation 98 and not ballooning right sides. TAPS is okay. Right ventricle moving up and down is okay. Visual TAPS is okay. And you expect if the pulmonary embolism cause shock, at least should make acute core pulmonale and right side dilatation. So you can exclude pulmonary embolism as a main factor in this shocked patient. No pericardial fusion, so we can exclude tamponading here. So we are talking about hypovolemia sepsis. Look, this fluttering interatrial septum is very easy and rapid clue about hypovolemia. Okay, let us see another view. 3-chamber view. Still apex akinetic, lower septum here akinetic, basal segment here hypokinetic. يعني mild hypokinesia of the inferior lateral wall. It's going with ischemic heart disease versus stress myopathy, but the patient is known ischemic heart disease already. Okay, this patient has ischemic heart disease. Okay, ejection fraction, we are talking about 40% ejection fraction. So it is left ventricular dysfunction and ischemic heart disease. We are ICU and emergency doctor. We are not relying a lot about ejection fraction. We need to know about the hemodynamics. Is there left atrial pressure high or not? It's not only ejection fractions, it is the physiology who guide us in the management. It is the hemodynamic who guide us in the management. Let us see. Thanks to these great guidelines, I talk a lot about these guidelines. American Society of Echocardiography, European Association of Cardiovascular Imaging Guidelines, 2016. It talk about if you have a patient with heart disease, like our patient, put the pulsed wave Doppler on the tip of mitral valve and look for the E ratio. E, which is the diastolic feeling of the left, passive diastolic feeling of the left ventricle, and A is the atrial kick. Okay, if the E over A ratio is more than 2, your patient with heart disease have increased left atrial pressure with grade 3 diastolic dysfunction. This patient is overloaded and need to be deloaded. Okay, but if the E over A ratio is less than or equal 0.8 and the E wave velocity less than 50 centimeter per second, it is normal left atrial pressure, grade 1 diastolic dysfunction. And if this patient has heart disease and hypotension, give fluids for this patient. It's safe to give fluids. If it is between 0.8 and 2, the ratio E to A ratio, you can measure 3 factors, and we discussed a lot about that. You will measure average E over E prime and tricuspid regurg velocity and left atrial volume index per square meter. Okay, we'll talk about that. Okay, our patient has ischemic heart disease. I put the pulsed wave Doppler at the tip of the mitral valve and I measure E to A ratio, the E wave. It is 42 centimeter per second, less than 50, and the EA ratio is less than 0.8. So my patient has, our patient has grade 1 diastolic dysfunction and no increase in left atrial pressure with narrow collapsing inferior vena cava. This patient, despite 1 liter IV fluids, please, you can give fluids. You are safe to give fluids for this patient. But please go to, before starting fluids, put the pulsed wave Doppler at the outflow tract, aortic outflow tract here, pulse wave, and fire the pulsed wave to see the left ventricular outflow tract VTI which is the Doppler study of the blood coming out of the left ventricle in the outflow tract, you can consider this left ventricular outflow tract VTI as a surrogate of stroke volume, and you can, before giving fluids, get the baseline, it is 12.6, and give boluses of IV fluids and keep measuring LVOT VTI as long as it's increasing by 10%, you are in the right way. Keep going with IV fluids until no more increase of LVOT VTI. That means your patient is full. Okay? And this is a link in my YouTube channel to see how to do LVOT VTI measurement live study very easy. This link is very helpful. You will see a live study of how can accurately measure the LVOT VTI live. Okay. Now I have narrow collapsing inferior vena cava, grade 1 diastolic dysfunction, ejection fraction 40% in ischemic heart disease patient. This patient needs fluids. But third part of our advanced critical ultrasound is the lung. There is A line all over. A line means the patient lung is dry. So all these factors, you have now 4 factors, assure you and relax you and reassure you to give IV fluids. A lines, it's dry lung. Inferior vena cava is narrow. And diastolic dysfunction grade 1 with normal left atrial pressure and dancing right and the left interatrial septum, denoting low pressure in the atria. All these are assuring signs to give IV fluids. In advanced our critical care ultrasound, we usually go to the kidney to document the low perfusion in this vital organ, which is the first vital organ to get the sign of hypoperfusion in shock. So kidney is very important to assess because it's the first organ to cry in shock. And I will give very important lecture recently about this microcirculation and vital organ circulation in shock. Okay? And our patient has already renal failure with rising creatinine. Kidney size is good, but echogenicity is almost more than the liver. It's grade 2 echogenicity, but normal size kidney. And as you see here, size is more than 11 centimeters, so it's going with acute process. And when you put the pulsed wave sample volume in the blood going through the kidney, in the renal artery branches, you will get this flow of the blood flow of the kidney. This is the systolic flow, and this is the diastolic flow. In any vital organ, diastolic flow should be good, almost 50% of systolic flow. This relation between systolic velocity and the diastolic velocity, systolic flow and diastolic flow, can be determined by what's called the resistivity index. If it should be less than 0.7. If more than 0.7, this kidney is crying. This kidney has arterial vasoconstriction because it is deprived of the blood. It's very important. We'll talk about this in detail in the next project, which will be really my case report about this microcirculation shock. It is very interesting lecture I will give recently, inshallah. Okay, now fourth part, the kidney is crying. There is there is vital organ hypoperfusion, which is the real definition of shock. Fifth, DVT, because this patient is bedridden and already has fractured femur. We have DVT in this patient. You see here, this is the left femoral, and this is the superficial branch of femoral artery. It's completely collapsing here, but you cannot collapse, compress. You cannot collapse and compress the left femoral because inside thrombus in this patient. But this thrombus is discovered accidental. It has nothing to do with the shock. It's not pulmonary embolism. 6. In our protocol, I will give you the link of our protocol at the end of the lectures. Usually, this patient has bad bed sores. He had now hypovolemia. He receiving increasing dose of levofed. We think about infection. So usually we'll go with a probe to the site of infection. We'll assess for pneumonia, for urinary tract infection. But in this patient, he has really severe pain of the anterior thigh, according to his wife. So I went by the high frequency probe to assess the anterior part of left thigh, and I found this abscess. You see here, in the muscles, there is abscess in the thigh here. there is dirty fluids, there is collection and wall up of collection in the left anterior part of the left side of this patient. So, fitting the puzzle together, narrow inferior vena cava, grade 1 diastolic dysfunction, small left ventricular flow tract VTI, and the A-line all over the lung, and the dancing, fluttering interatrial septum right and left, denoting low pressure in the atria. You can give fluids whatever ejection fraction is. This patient has apical akinesia, septal hypokinesia with low ejection fraction 40%, but it's safe to give fluids. It is rarely to be obstructive shock due to pulmonary embolism, despite DVT, because patient is fully saturated on minimal oxygen supply without respiratory distress. Normal right side ventricle with good visual tapsy. The right ventricle, you will expect it to dilate in case of obstructive shock due to pulmonary embolism. Presence of left upper anterior side abscess with hypovolemic profile makes septic shock as a main element of this patient. Okay? So, what are you going to do? Now, advanced critical care ultrasound. By the probe, we document the shock, we document the organ perfusion, which is the real definition of shock. Definition of shock is the organ perfusion, is the organ hypoperfusion. It's not only blood pressure, it's the organ hypoperfusion. But what about treatment? How can advanced critical care ultrasound help us in treating the shocked patient? Main treatment of shock is the proper IV fluids, proper selection of immunosuppressors, and the treatment of the cause. We already know the baseline LVOT VTI, it's grade 1 diastolic dysfunction, A-line all over the lung. We keep going with IV fluids. There is a practical point here. I usually, for this septic patient with hypoalbuminemia and the cardiac ejection fraction, low ejection fraction, I prefer colloids, not relying purely on crystalloids. I prefer to mix between colloids and crystalloids because you don't shift the patient to pulmonary edema, because this type of patient can be shifted to pulmonary edema with low left atrial pressure. You not expect the left atrial pressure to reach 18 or 20 to get pulmonary edema. It can get pulmonary edema on 12 and 13. For this patient, I keep boluses of purified protein derivatives, albumin 5%, and saline. He received 1 liter of albumin and 1.5 liter of normal saline. And it was the baseline LVOT VTI, and I keep giving IV fluids as long as the LVOT VTI is increasing by 10%, and I stopped once LVOT no more increasing. Okay, and it's very important practical point here. I keep going with IV fluids until I convert diastolic dysfunction grade 1 to grade 2 diastolic dysfunction, plus keeping eye on A-line of the line. So, I am doing two things. I am giving fluids to increase LVOT VTI by 10%. That means my fluids is increasing stroke volume. At the same time, I am following left diastolic dysfunction and LV left ventricular pressure, because increasing diastolic dysfunction from grade 1 to grade 2, that means you increase the left atrial pressure, and I think it is fair enough to stop here to give fluids in this patient with renal failure and low ejection fraction. So, I give boluses until I reach my LVOT VTI 16.4, and after that no more increase happened really, and the 16.8, no significant increase, so I stop IV fluids, and I follow the left ventricular diastolic dysfunction in this patient, and when I reach, as you see here, E velocity, the EA ratio, it is less than 0.8, but the E velocity, it's more than 50 centimeters per second. That means you should think about grade 2 diastolic function. To document grade 2 diastolic function, you need to assess three things. First, left atrial volume, and for this patient, 92, it's when you convert to body surface area, it is more than 40. That means this patient left atrial volume per body surface area is more than 34 milli per meter square. That means this 1 point positive, left atrial volume is increased. That means 1 point positive towards increase the source function. And when I assess the velocity of tricuspid regurg here, it reached more than 280 it's 296. That means it's another 2 points. So I cannot do the third one, which is E over A prime. With these 2 points, left atrial volume more than 34 milli per square meter, and the tricuspid regurg velocity more than 280 centimeter per second, I reach to grade 2 diastolic dysfunction. And this diastolic function is amazing, and it's very important to master it, to master advanced critical care ultrasound. This link will help you a lot. This is very clear lectures about the new American Society of Echocardiography and the European Association of Cardiovascular Imaging. These guidelines of the diastolic function, which is guiding us in IV fluids to diagnose left atrial filling pressure. This very clear lecture with videos and pictures, and you, I believe you will understand these guidelines properly if you go through these lectures. Okay, it's in my YouTube channels. Okay, and the following lung A line is going on. So I keep going IV fluids in this renal failure and heart failure patient by following left ventricular outflow tract VTI increasing by 10%, and at the same time following the diastolic dysfunction and left atrial pressure, I need to shift the grade 1 diastolic dysfunction to grade 2 diastolic dysfunction, and I think it's fair to stop here with grade 2 diastolic function and keep eye on the A lines, because presence of P lines, that means your lung start to be wet. And as I told you, in this type of patient, septic patient, cachectic patient, bedridden patient, you expect hypovolemia and you expect pulmonary edema with low left atrial pressure. Okay, now as you see, our patient tricuspid regurg velocity is more than 2.8 meter per second, and left atrial volume index more than 34 milli per square meter. So 2 points of these positive, that means 2 of 3 positive, that means increased left atrial pressure, grade 2 diastolic dysfunction. But still our lung is A lines, it is safe. We give fluids, we increase perfusion to the vital organs, but we didn't cause harm to the patient by hypoxia and pulmonary edema. Second part of treatment, proper treatment of shock, is IV fluids, and as you see, we give fluids in target and the planned way and safe way and effective way. But what is the second part of proper treatment of shock? Is the proper inopressor. According to the main diagnosis of the shock, our patient has septic shock and the ejection fraction is not badly decreased, so we continue on noradrenaline, because noradrenaline is the best for septic shock. So according to the type of shock you get by advanced critical care ultrasound, you will give the proper inopressors. What is the third part of treatment of shock? Is the treatment of the cause. It is very important to treat the cause. Okay, treatment of the cause. In our patient, I guided first in the ER. I put the color scale here to guide my needle, because I remove almost all these fluids and send for the culture and call the surgical team. Okay, but before doing aspiration, you need to be sure no vessels in the path of aspiration here, because you don't need to cause harm for the patient. So this color, it's a must before ultrasound guided aspiration of this collection. We took a sample under ultrasound guide. We take almost 20 cc and centigrade stain culture, and broad coverage antibiotic started at the call surgical team. At the end, these are the link of my protocol for full management of shock. This is the link for how to diagnose almost all cause of shock, and this is the link for the proper treatment of the shock. I think it will be helpful a lot, these links. I give you several links you can follow in my YouTube channel. And thank you a lot for your appreciated listening, and see you again in a recent project, which will be a great really, because we'll talk about very important point, which is the perfusion of the vital organ in shock. We'll not talk about VTI alone, we'll talk about the vital organ perfusion by advanced critical care ultrasound, and I believe it will be the future treatment of shock. See you soon. Bye bye. Bye bye.